Good morning, Kansas City. This is Steve Stites, Chief Medical Officer at the University of Kansas Health System. I'm here in the Dolph Simon studio, and we are broadcasting live to talk a little bit more about coronavirus and COVID. A couple of good folks with me. By now, you all know Dr. Hawkinson, Hawkeye, our Medical Director of Infection Control, Infectious Disease Physician. And this morning, we have a special guest, Steve Lauer. Steve's a good friend, and he is the Vice Chair of Pediatrics here at the University of Kansas Health System, he's just a great physician who is great with kids and great with people. So before we start taking questions, wanted to see if our guests today have anything they wanted to highlight. Dana, and how are the numbers today?
Yeah, so before we get to the numbers, I think everybody has maybe seen stories about the projections and saw Dr. Fauci talk. You know, things may be looking okay. We want to be
better. Well, let's not say okay. Let's just say they're better.
Better. Okay. We don't want to be too optimistic because they can change. So we're working on that. You know, there are trials out there for drugs and therapeutics for treatment. There are trials for vaccines going on. You know, if we get a vaccine, it could be 18 months, that was floated out there. But I have to remind you that even for other vaccines historically, like polio, it took almost 50 years to create a vaccine. So this is a very fast track. As far as our numbers are going at the hospital, currently we have 29 inpatients. 12 of those are in the ICU, and 9 of those are on the ventilator. So about the same.
Yeah,
the same.
We like the same.
Yes.
We'd love to even more saying it's going down. You know, it is actually down slightly. We had a peak of 14 patients on a ventilator,
Correct.
And we had up to 34, 35
Right.
patients at one time. So we're technically
And day to day, this includes discharges as well as new admissions. So it's not just the same people that we've been talking about. So.
Exactly. Steve Lauer, you've been so helpful in KU's efforts working with Children's Mercy and the combined department of pediatrics and have done such great work here. I know you've even put together a kind of a frequently asked questions site for kids, which is a little different since I think the emphasis often around is on adults with disease.
Yes, well, on the website, the kansashealthsystem.com website under pediatrics.
Good morning.
There are a bunch of questions that have come in from the public that we've tried to get answers out there for. Overall, I think the good news from our side is that children seem to be doing fairly well with this infection. While they certainly can become ill, most of the time they seem to not becoming really sick like the elderly are. So far they're managing pretty well. Within our department, we're working hard to adjust to the telehealth modules and figure out how we can continue to see patients both in telehealth and when needed in clinic.
Thanks a lot, Steve. And a special shout out as well to our interpreter today, Michelle. Thanks for being back, and so appreciate your help. So I suspect there may be some questions out there. Anyone, reporters, anybody? How are things going?
This is Sheriff 4. I have a question about antibody testing. There has been some clinics that have popped up around town offering antibody testing for cash of $20 to $50. Is there an antibody test that they could be giving out? And if not, it's safe to say that they're probably fake and what people should look for? Because apparently people are running to these places wanting to know if they've at least had it.
Yeah, what's that old saying? Beware of whatever, something bearing gifts. Dana, thoughts about the antibody clinics that don't really work yet?
Yeah. Well, I can talk about the antibody test because that has come up a lot. We feel at the health system that absolutely it will be very advantageous to use serology or antibody tests to look at the prevalence of the disease in our community. What we also feel, however, and we have some very bright minds in our lab working on this, is that in the current state, the antibody tests are not validated to produce the amount of sensitivity and specificity, meaning they aren't validated to produce the correct answers that we want in the amount of times that we want it. We want to make sure that if we're testing you and it's a positive, that is truly positive and you've truly had exposure to coronavirus or COVID-19. And if it's negative, that you truly have not had exposure to COVID. So we are working with different companies and we are continuing to evaluate and validate those types of tests. And when they are meeting our standards, we will certainly employ those and employ those in ways that we can be helpful to the community.
And just to say, there are a bunch of coronaviruses out
Absolutely.
there. It's not just SARS-CoV-2. Last Friday, the FDA said they didn't really believe that the current antibody tests that were in the market and commercially available that people were using could truly distinguish between the different types of coronavirus. So you may test positive, but it may not have been SARS-CoV-2 and could give you a very false sense of security. So I would be very cautious about using those tests until we have one that is FDA approved and is felt to be highly sensitive and highly specific. Because if you want to get into math, what happens is if your pretest probability isn't very high and you test positive, there's a really good chance it's a false positive. And so that doesn't help you, and it may give you the sense of security that you're made of steel and you can leap tall buildings. But the reality is that you're not going to do much leaping if you have COVID-19, and the antibodies you have, if they were really to the common cold coronavirus and not to SARS-CoV-2, aren't going to help you. They don't help you. And so I'm reluctant about those until we're really confident that we have a true answer, not just an answer, a true answer.
And the way we use that test as well, not to diagnose an acute infection, but also we should note that certainly studies from China, from Korea, they have shown that even if you have had the disease, mild, moderate, even severe, there are cases where you may not mount antibodies, where they can't detect antibodies, and that's a scary thing as well.
And you may have recovered.
Right.
Right.
Yeah.
There are a fair number of patients. So, in this rush to judgment, about and everybody wanting to know, just be real careful out there. I would say to people, be thoughtful, be thoughtful about it before you go pay money. Next question.
Hi, good morning. It's Amy Anderson at KCTV5, and I was just wondering, Mercy Hospital in St. Louis is treating 3 patients right now with plasma from patients who've recovered from COVID-19, and I wanted to find out how far off we are from doing that, and just get your thoughts on that at this point.
Yeah.
Yeah. Go.
Yeah, that's a very good
Okay.
question. In fact, I've had one of our, well, I guess our employees, I'll just leave it at that, who have contacted me because they were positive and wanted to donate plasma and convalescent serum. We are actively in the preparations of the trial right now. Again, since day one, we've had a therapeutics group who've been working with treatment algorithms with hydroxychloroquine, azithromycin, other things. One of our researchers, one of our ID physicians in that group has been active in this for probably about a week or 10 days now and is working to get the trial going here, has been in contact with our IRB, which is just one of our research bodies, to make sure that we're doing everything above board, and has also been in contact with Community Blood Center as well. So we are actively pursuing that, and hopefully within the next couple days that actually will
Yeah,
be
I heard
going.
actually it was approved yesterday, so
Okay,
I think it
well,
may
there
be
you go.
ready to go.
Yep.
But it's the thing. You just have to be thoughtful about it. You take the plasma from usually more than one donor, and you pool that together, and then you give that to somebody who's sick. You don't just give it to everybody who gets COVID-19. You give it to people who are sick and not recovering well. And what we don't know is how well that works yet. There's some anecdotal data, which means, hey, I've got a case of 3 people and they all got better, which is, that's kind of where things start, right? When you have something like this, that suggests that this does have better outcomes in Europe and in China. And we are set to do it here. There's been a few cases in the bi-state area that have had that. So, but ours is under a research protocol, so we can actually measure the effects of that, turn that in, and be part of a national reporting. So it took us a little longer to get that done because we wanted to make sure that that was all reporting up to a national database in order to have people be able to study that information later. So you have to kind of give it in a controlled way, do the right thing, have patients sign that consent form.
We want it to be safe for the
Yep.
patient. It's not a menial amount of plasma or fluid either. One of the research studies showed 200 milliliters. That's a pretty small amount. Typically, it's probably going to be more than that. But also the timing of this. When do we do it in the infection? Can we give it any time that you were diagnosed, or do we have to do it early or late? And so that's something we're also helping to learn as well.
Any idea as far as if you're going to donate plasma, how how long do you have to be free of the virus, and how would you even know when you're safe to donate if that came around?
That's a great question.
Yeah, that's a good question. So we do understand that most people will mount an IgG antibody response by about 11 to 14 days, certainly after 14 days. So I think if you've been diagnosed with the disease, probably waiting 2 weeks. I think the best thing to do is probably call the community blood center to ask. They probably have guidance on that.
Yep, I think that's right. Community Blood Center would do that. You don't donate here at the hospital. You donate, and it's got to be at least 2 weeks. I think it's more like 3, because what we're seeing is some people get a second wave of this illness, and they may or may not still be positive, but they get sick again later. Not as severe. It kind of comes and goes in waves a little bit, and so we need you to get pretty free of that before you're going to be donating to make sure you're not donating live virus. Other questions?
Hi, this is Nate from the health system. What do you think about folks or even medical professionals talking about building herd immunity? And can you speak to that?
Okay, let's talk about herd immunity.
Well, I think as far as vaccination and pediatrics, I think we should start there.
All right, Steve.
That's the main.
Well,
Because we all know
Yeah.
the kids are like the vector.
Yes.
They spread
Yeah, the
this
vector.
disease because they don't even hardly get sick.
right. Well, that's so part of the problem. A good thing for the kids, but they're really not getting that sick. And there's certainly this whole group of asymptomatic carriers that seem to be a case, especially among the pediatric group. The problem with building herd immunity right now, I think, is that we don't have any idea of how big the herd is. We just don't know how many people have been infected, how many have recovered, and so it's really not possible to get I think, reliable sense of herd immunity.
Can you explain what herd immunity is?
So just the idea that as a group of people, a big population, as the disease spreads through it, that enough people have had the infection and are immune to it, that the disease just can't pass very effectively among people. It keeps running into people who are immune to it, and so eventually it doesn't pass around within that population. The way we really like to get to herd immunity now is immunizations, and that way everybody can be immune without having had to suffer the disease, and many of them get really sick and in some cases die from it. So the real way to get to herd immunity, I think, is to get that vaccine out there, and in between now and whenever that does become available, having people be protected as much as possible from becoming ill in the first place and not take the chance of becoming really ill with the disease.
Beautifully done, I think. So I wanted to, there's a question I want to kind of pile onto that, and one of our listeners, Cindy, asked a question about whether it's kind of like that line from Jaws, is it safe to go back out in the water? I'm not trying to make light of it, but it's a real concern, just to say. So for people who have diseases of their immune system, or heart failure, or transplants, or chronic lung disease, as we start to open up society, you're thinking, gosh, that means more people with the disease can be in contact with folks because we're opening things back up again. And that is a real fear. We think that only about 1 or 2% of Kansas Cityans have actually had, in our area, have had this SARS-CoV-2 virus. That's a pretty low proportion. Mm-hmm. We are seeing the flattening of the curve. I mean, we just are, and that's great news. And just, may I say, hats off to everybody in our area who have done that, because, you know, you've demonstrated to the country how to do that. That is a remarkable statement. There are some of the researchers and epidemiologists out here at KU and other places say we may have seen the peak of the curve. I don't know if that's really true or not. Makes me a little squeamish to say that. I'm not sure. But the point being, we have clearly flattened it. So that's really good news. But we've also flattened it without a lot of people having gotten that sick yet. We're nowhere near what's happened in New York. So what has happened is folks have sheltered in place, stayed at home, maintained their distance, which we've wanted you to do. Absolutely the right thing to do, because if we didn't, our healthcare systems would have been overwhelmed, and we would have had a lot bigger problem on our hand. But our next problem is that as Steve has said, if you don't have enough people who have been infected or vaccinated, then it's easier to pass the virus. So for people who are at home with different diseases, that's a little bit of a scary thought, because it means when society starts to open back up, then you could be around people who may be carrying the virus. And what I would say is that it's still very possible, even in that world, for you as an individual to remain sheltered. Because that other parts of society may open doesn't mean if you have a significant chronic disease that you need to do that or should do that until such time as we know we have effective therapy. We can better predict what the risk factors and how you're going to get infected, or we have vaccinations. Vaccination is really the ultimate answer, because it's not treatment, it's prevention. So it is a real fear, but it's going to be a fear no matter when we open up the society again. And the real key for any individual who feels vulnerable like that is to make sure you maintain your 6 feet, to make sure you wash your hands for 20 seconds, you cough into your elbow, you don't touch your face. Ask the people who come around you, or not tell me if you're sick, you can't come in, and wear a mask. I mean, if you do those things, you will really protect yourself against this and any other bad disease like influenza. And remember, influenza is pretty nasty too. So I think that there are things you can do to stay safe even as society starts to open back up. Also knowing that if and when we do that, well, not if, when we start to reopen society, we have to do it in a cautious, logical, and thoughtful format. And that's the discussion I hear going on in Topeka and in Jefferson City, as you can't just do it with reckless abandon.
Yeah.
So, and then you have to avoid really large public gatherings like where I want to go, Kauffman Stadium or Arrowhead Stadium or places like that. So, for a while, till we get vaccination. Next question.
This is Nate again. I had somebody asking about proning. Can you talk about proning patients, and have you seen if there's any evidence for early proning of non-ventilated patients?
Yeah, it does actually. Well, in mechanical ventilation patients. So proning, without trying to get all fancy about this, what happens when you lay down and you're on a ventilator and you're on your back, right, is that your body gets leaky. And the excess fluid in your lung tends to settle in the back part of your lung, the part of it that's down, not the upper part. But so too, air tends to go to the path of least resistance. Well, if you're laying down, most of the air is going down and not in the upper part of your lung. If you think how I could divide my lung, if I'm laying flat, I could divide my lung into the upper part and the lower part, and most of the air and all the fluid goes in the lower part. What proning does is it says, gosh, all that fluid can get in the way, so if we turn you over and ventilate the front part of your lung, then all of a sudden the ventilator is going to work better and you're going to do better. Proning definitely is important in COVID-19. It's very important in lots of types of different lung diseases that have led to needing to be on life support. So eventually the fluid can then get into the front part of the lung, you flip over to go to the back part of the lung. But that's what proning ventilation is, and it's mostly used in people who are on ventilators. It's a little uncomfortable and harder to do on oxygen therapy without a ventilator, but it really can work very well, and it's a very important part of COVID-19, especially earlier in the disease. In the later stages, when your lung tends to be more scarred, proning doesn't make as big a difference, but it really can be helpful in the earlier part of the disease. Next question. Hey, I could actually answer one. That was good.
Yeah.
That
was an awesome answer.
It's not bad. I think I might even been right about it, so it's going to be good. I may have actually given out good information.
Well, there's questions I'd like to add too. The epidemiology of herd immunity is simple, but it's also complex. It's not, as we just heard from Dr. Stites, maybe 1% to 2%, maybe 10%. We don't know how many have been infected. But for herd immunity, you need 80 to 90% of people, because if only 50% of the people have been infected, 50% of the people could still be infected. And that's just the epidemiology. The immunology of this disease is amazing. It's incredible. We still don't know all the answers for that either. We know that most people can probably mount antibodies. We talked about that. Some people don't mount antibodies, but still get better. But the antibodies, how long do they last? How long can you be immune? We've certainly seen reports that people will either have a relapse disease or possible reinfection. If you get reinfected, is it a more mild form. That might be true, but why did you get reinfected in the first place? So there's still a lot of questions at the molecular and cellular level that we still haven't answered, and hopefully as we move forward we get some of those answered and help with herd immunity and immunity in general.
You know, years ago, I used to be an ICU doctor. I don't really do that anymore. But I, for 25 years, did. And we had these rules in the ICU. I used to try and make sure everybody knew, like, save the patient, do the right thing, do no harm, make sure the numbers look good, and make sure you got everything kind of well lined up. One of the rules was to know, you've got to know what you don't know. And one of the things we have to be aware of with COVID-19 and SARS-CoV-2 is while we've learned a lot, there's a lot we don't know, and we have to know what we don't know if we're going to really treat people right. If you start thinking you know the answers when you don't, that's when you make mistakes, and that's when you hurt people. What I'm impressed by, and by our team, is that, I think we've got a pretty good understanding of what we don't know. And so you don't want to jump to the nearest thing just because it sounds cool and different, because you could actually violate the first few rules. You may do harm because you don't know what you don't know. You don't know what the other effects of that are. And so you have to be thoughtful and practical in what you're doing to treat people. Otherwise, you can cause harm. And in something like this, you may only get one shot at doing it right. And so you've got to know what you don't know.
Yeah.
Speaking of that, we do have a question on, do you need to be taking aspirin in light of that this disease causes blood clots?
Blood clots and aspirin. Okay. Everybody's looking at me. Here's what I think.
answered that yesterday.
Aspirin is not anticoagulation in what this disease does. And so really there's a different classes of anticoagulation that will work better in this world. Aspirin is really not probably the right therapy. It may even have some negative side effects that you don't want to have in this disease. So I would be hesitant to prescribe aspirin for COVID-19.
I would say one of the things that got out early and has since been taken back was the idea about it was bad to give, could be damaging for kids to get ibuprofen while they were sick. And just to be clear to everybody that was quickly turned around, and in episodic use, when used appropriately to help with the fever in children, ibuprofen is fine to give.
Yeah.
I want to see Michelle give that symbol for quickly turned around again. That was impressive. I was like, no, that's bad.
Could I, just to follow up on one other thing, that talking about herd immunity, one of the things that is really important while we're fighting this one infectious disease is to keep up the herd immunity on all the other important childhood and other diseases.
Absolutely.
So we continue to do the visits where we're getting, especially the infants and toddlers, their vaccines against all the vaccine-preventable diseases. We, as far as I know, have not seen a case of Hib meningitis here in a very, very long time, and don't want one of the side effects of this crisis to be the reemergence of these vaccine-preventable diseases. So very important for everybody that those visits, in-person visits that require vaccinations, keep up during this crisis.
Yeah.
I would agree. I mean, I think that we're dealing with one thing here for the most part. We think flu activity has really declined. I saw, there are other countries that are dealing with other epidemics right now as well, things like dengue and things of that nature. So if we can just deal with one epidemic or pandemic, let's do that. I saw Dr. Norman also did tweet out, I think, about congenital syphilis epidemic going on. And again, that's not a vaccine preventable, but we don't want something else like measles, mumps, rubella, chickenpox, things of that nature to reemerge if we have a good, safe, preventable way to keep them away. So I agree.
Questions?
Hi, this is Nate again. Do you want to talk, I know you touched on this before, about zinc and quinine and how and if they will prevent COVID-19 infections, or if they're good to be used for critically ill patients infected with the virus?
You bet. Guys, Dan, you want to start with that? The answer is no.
Yeah. The basic short answer is no. There has been no compelling evidence that, one, there is, treatment, there was a recently published study for remdesivir, but for the most part, for hydroxychloroquine, azithromycin, zinc, there's been no compelling evidence that those are efficacious in treatment of this disease, and there has certainly been no compelling evidence that any of those things, such as zinc, quinine, are efficacious in prophylaxing or protecting you from this disease as well. So yeah, the basic answer is no. I don't think taking zinc supplements or vitamin C supplements will cause you harm if done in the correct manner, but certainly there's no evidence that that will protect you from this disease.
Anything you want to add to that, Steve?
No.
No. Okay.
We have a healthcare worker asking if they have asthma or diabetes, should they be working?
That's also a really good question, and so let me try and take a stab at it. It's all about a degree of severity and your level of risk in what you do. What we know is that if you're wearing the right protective equipment, your chance of getting SARS-CoV-2 at work is much lower than it is if you go out into the community, just going to the grocery store, if you're not protected. Right, because when you're at work and you're facing patients, you're probably going to have a gown, glove, mask, and face shield. When you go to the grocery store, maybe you're wearing a mask. So where are you really more susceptible? You're probably more susceptible at the grocery store. So the way we've approached it is that we've said that we will not have anybody come in unless they are, if people are concerned about their own health. As a healthcare worker, we try to look at the degree of concern that we have about whether or not you could be infected. And again, for the most part, if people are wearing their personal protective equipment correctly and taking it on and off correctly, the risk of transmission is incredibly low. And when we were talking to the folks out in Wuhan, China, what they told us was that their healthcare worker transmission occurred with donning and doffing, and when they were wearing really complicated hazmat suits and things like that. It didn't occur when they went to standard droplet, which is gown, glove, mask, face shield. Dana, anything else about that?
Yeah, no, I mean, I think that we, again, at this point, we have adequate stores of PPE. We have our training with hand hygiene and appropriate donning and doffing, and that's what's going to protect our healthcare workers, but also our other patients, because we do have cohorting. We have certain units or floors where our COVID rule-outs or COVID-positive patients are, and so that's all in an effort to protect our other healthcare workers as well as our other patients.
And I would say if you're, no matter what your age, a patient with a chronic disease needs to be working with their care team to keep that disease under good control all the time. So the less severe manifestations of your disease you have at any time, the less risk you're going to be at.
And for those who are really have severe chronic diseases, what we've really said to our folks is, look, within, let's say, a physician practice group down in the emergency room, because they're one of the more higher risk groups for physicians, if your partners can all do the work, that's great, and have you do a non-COVID area, that's great. At the end of the day, though, we all have to be in line if a really severe surge comes, is what we've seen in New York. Hopefully we are not going to see that in Kansas City, because I think all the measures we have in place have really worked. Time for one more question. All right, not hearing one, then I'm going to look at our panelists and say, guys, is there a message that you would like to send today to all our listening audience and to the media team who have been working with us? Dana?
Well, I think that, again, as I stated earlier, the recent press conferences from Dr. Fauci and projections seem like they're looking better. We don't want to be too optimistic, but there's still a lot of work to do, because we all want to get back out into life. We want to enjoy our family, our friends. We want to be outside. We want our other non-essential businesses, or, in quotes, our service industry, our bars, our restaurants, our economy to flourish. I think there's still a little bit of time. We still need to wait for the final amount of data. We have that time until some of our shelter-in-place orders are lifted, and if we can wait and get the amount of data, and then once we know that, do the right thing, I think we'll continue to be on the right course.
I think everybody is, of course, interested in getting getting out there and getting life back to normal. But again, the way this has been brought, if we can say it, under control, at least flattening the curve, is following the shelter in place, wash your hands, cover your cough. All of those are the simple ways that this is getting closer to being under control. And I'm just concerned that the biggest mistake we're going to make as a society is to go back too quickly and force us into having these conversations again in 2 months or 4 months. So really staying the course on this, being careful. This is not going away. It's something we're going to have to deal with for many, many months. And so these basic rules are going to be there. The better we stick to them, the healthier everybody's going to be.
There's herd immunity and there's herd mentality. Herd immunity is a good thing. Herd mentality, not so much. What we have to be careful with is that as we begin to strike this more optimistic tone here, because things are looking a little better for that, we have to remember that COVID-19 is going to be with us for a while. As Steve has said, it's not going to go away. And that's, that's a challenge to all of us. What it means is that even as we begin to reopen society, it's not going to look the same. It is going to look different, because we're going to have to be respectful of social distance. We're going to have to wash our hands. We're not going to go out into large gatherings for a while until we know that we have effective therapy and immunization. I don't know what all that means yet for baseball and football and basketball and restaurants and bars and places we all like to go. What I do know is that there are important rules that will keep you safe. They're the same things that have kept you safe now, right? We have defied national projections here in Kansas City. And what we need to do is keep being a little bit defiant around those projections and saying that if we work to stay safe, even as we start to reopen this world, if we work to stay safe, we can beat COVID. And that's the job. That's our goal. So stay safe, shelter at home, keep your distance, wash your hands, cough into your elbow, don't be a guy and touch your face, and most of all, have a great day. We'll talk to you tomorrow. Thank you all very much.